I'm going to talk to you about the imaging in spinal fluid leaks. Actually, my kind of introduction to the things that predispose to it, when you should think about it, how to find it, is actually in tomorrow's talk. But keeping in the theme of radiology, I wanted to go over some of the imaging characteristics related to spinal fluid leaks for people who are headache specialists. No disclosures. I do want to say thank you to the Considine CSF Leak Fund, which helps support me doing stuff like this. And all the stuff that you see here is not, in fact, carried out by one person, but product of a team at Stanford, including Rob Cowan, the director of the headache program, a number of the headache faculty, neuroradiologists, and neurosurgeons as well. So let me start with a basic case. This is the thing that gets diagnosed as a CSF leak all over the country, very straightforward. This is a 70-year-old woman. She fell down, woke up, had a postural headache when she got up after falling down. They imaged her to try and figure out why she was hurting, and you can see immediately apparent that the dura, all the way around, is enhancing. This is called pachymeningeal enhancement. You only see this on a contrast-enhanced MRI, and it's a function of the fact that when the pressure inside the skull drops, the veins and the little venules in the dura distend, and if the veins are currently carrying gadolinium contrast, then you'll see this kind of contrast enhancement. Perhaps a little more subtle is that the pons here is kind of bent up a little bit towards the midbrain, what's called beaking. And so this is a structural alteration that comes along with what's called brain sag. You don't see a ton of, and it's a little hard to see in this scan whether the cerebellar tonsils have made it beneath the foramen magnum or not, but this little kind of, how the pons is kind of bent up here is a sign of sag a little bit. This is what it'll look like on a coronal. This is a classic coronal MRI for someone who has a spontaneous intracranial hypotension due to a CSF leak. All right, this is pachymeningeal enhancement. If someone had meningitis and you were worried about dural enhancement, you'd get leptomeningeal enhancement, which would kind of dive into the sulci here. But this kind of smooth enhancement is what we're looking for with a leak. And the other characteristic of it is not only is it smooth and thick, but it's wrapping all the way around the temporal lobes, really encircling the whole brain. And so the question then becomes, where is this leak occurring? And I want to point out that in this MRI, what you see, if you're following the thecal sac, so the water here, this is a T2 MRI, the water here is bright, the spinal cord is dark. You'll notice that the subcutaneous fat is dark. This is a fat-suppressed image so that the epidural fat will not be bright, making it easier to see if the fluid makes it into the epidural space. And all you have to do is kind of follow the border of the thecal sac to notice that right here, something's kind of poking in, and you see this little intensity here, and I've blown it up on this side to make it a little more visible for the people in the back of the room. And in fact, there's been a little compression fracture in this vertebra and a little retropulsion of something here. But you don't see any fluid leaking out, and this is the only place where it looks like there's any deformity that's kind of impinging on the thecal sac, so we wanted to get a better look at this. So we did what we do often when we can't tell where the leak is coming from. We got a CT myelogram. I want to show you on the axial, you do not see any fluid leaking out here. This is the best MRI you can get of the spine to look for a leak. And there's clear brain evidence that there's a leak. But notice on this spine MRI, there is no evidence of a leak at this place. Now, you could wonder, maybe this is a couple of millimeters below. Is there a little ventral fluid there? And is the dura right there? And then this, just a couple of millimeters away, but only a couple of slices with what looks like T2 hyperintensity fluid signal outside the dura. On a CT myelogram, this is what you see. Again, a little compression fracture here. And notice at the top of the compression fracture, you have this little calcified fragment jutting into the thecal sac. Again, this is a CT myelogram, so the fluid is white because the contrast has been injected in it. You've got the spinal cord here. And this is what it looks like on the axial. Look at that nice little calcified spike poking right towards the dura. Easy to see why someone with this would suddenly develop a leak. But again, what you do not see is a well-contained fluid collection here. In fact, the only thing you see, if you look just a little further away, just up or down at the adjacent segment, a little kind of puff here and there. And that is it. That's what she looked like after getting patched. And that's the basics. That's like a generic CSF leak case. Nobody sees it as controversial, very straightforward. The imaging's positive. Now I want to switch gears a little bit to talk about, frankly, what's probably 9 times more common than that among the leakers. So I'm going to show you some images from a 37-year-old woman whose symptoms began in 2015 without a clear inciting event. Okay, so 34, no real history of headaches, suddenly starts having the symptoms that I'm going to tell you about. She first noticed that she would get dizzy and get headache and see stars during and after Pilates. And then she goes to an amusement park and gets on some of the rides in October 2016, gets much worse. All right? So for me, this is actually a good story for a leak. And I'll tell you why in just a second. We had her do something that we call a 48-hour flat test. With spinal fluid leaks, typically they get better the longer you're flat and worse the longer you're upright. When someone has an acute lumbar puncture and it's a new leak and it's down in the lumbar space, you usually see that postural difference very quickly. However, if somebody has a leak for any considerable amount of time, meninges start getting inflamed, you've got to be flat significantly longer to feel better. And often, if the leak is not a fast leak, you have to be upright for a longer time as well. And so what we do is we tell people, listen, on a Friday night, when you get home, you've finished your week, you're going to write down your symptoms, the symptoms of a CSF leak, which include headache, neck pain, nausea, cognitive disturbance, memory, difficulty with concentration, ringing in the ears, and fatigue. You're going to write down on a 0 to 10 scale how severe that is, and then you're going to go lie down. On Saturday morning, when you wake up, you're going to pee and get right back to being in bed flat. Then you're going to stay in bed flat all day, do the same thing Sunday. By Sunday at 5 p.m., if you have a leak, you should feel significantly better. You've been flat for about 36 hours, 48 hours. And then what we want you to do is get up and start walking around and see if 2 hours later your head pain and other symptoms are back. Is it really something that when you spend more time flat, you can really start to see this postural component? So here's her head pain. She starts at a 7 after 48 hours flat as a 0. 2 hours after getting up, she's back to a 5. Neck pain, 705. Nausea, doesn't have nausea. Cognitive symptoms, 404. Tinnitus goes away when she's flat for 48 hours. Fatigue is much better on being flat too. Okay? Now, Dr. Shivink and Dr. Louie at Cedars-Sinai, who Christina mentioned, they run the CSF leak program there, published the best paper about precipitating factors in people with spinal fluid leaks. And the take-home message for you guys is that only 30% of people with spinal fluid leaks can point to something like the first case I showed you. They fell down. They had a trauma. Only 30%. 70% of people with CSF leaks can identify no precipitating trauma at all. The idea that you're going to say, oh, this really isn't the leak, they can't identify any kind of trauma, they didn't have a whiplash, just not true. Among the 30% who were able to identify a precipitating event, look at this. Yoga, 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 yoga pulling the head up. And then, for good measure, amusement park ride. All right? So the Pilates and the roller coaster resonated with me. And this is what her MRI looked like. Substantially different than the classic case I just showed you. Okay? This was read as a normal MRI. And I suspect in 98% of the country, this would be reasons for not pursuing a CSF leak any further. However, and notice, again, contrast was given here. None of that pachymeningeal enhancement. However, when you in fact measure some of the distances in her brainstem, what you see is, first, the distance between the top of her pituitary and her optic chiasm, what's being called the suprasellar distance, is 2.6 millimeters. The distance between her mammillary body here and the top of her pons here is 6.2 millimeters, and the distance between the front of her pons and her clivus is 4.89 millimeters. I've drawn McRae's line here for you just so you can see her cerebellum tonsils come down to it, but don't go below it. She doesn't have clear brain sag, but these measurements are going to be important. So this year, in my field, the most important paper that came out was published in JAMA Neurology by a consortium of Swiss and German neurosurgeons, including Jürgen Beck. Where is he? There he is, Jürgen Beck, who's kind of the German version of Wouter Schievink at Cedars-Sinai. He's kind of a pillar in CSF leaks and in that field. And what he did was very interesting. He said, listen, we need something better than just this obviously recognizable pachymeningeal enhancement to know when we should be calling an MRI positive or negative. And the right way to make that decision is to see what findings on an MRI actually predict someone having a leak visible on a CT myelogram of the spine. What brain findings predict a positive spine myelogram showing a leak? So he gathered 56 people who had CSF leaks confirmed on CT myelogram and 60 controls, normal brain MRIs. And he compared the brain MRIs of the cases who had CT myelogram confirmed leaks and the controls, normal people, normal MRI brains. And what he found was some of the distances previously reported in several papers, including the suprasellar distance, this mammalopontine distance, and this prepontine distance, actually were as important at predicting whether you were going to have a CT myelogram as that pachymeningeal enhancement. And so neuroradiologists across the country are not doing this yet. This came out this year, but basically he then made a multivariate logistic regression model of what findings on MRI are going to in fact predict you are going to have an increased likelihood of finding a leak if you go forward with a CT myelogram. And the nice thing is you find that in fact the things you expect are predictive. That pachymeningeal enhancement predicts whether you're going to have a positive CT myelogram. And venous sinus distension, which has been previously reported, also predicts a positive CT myelogram. But these little subtle measurements, suprasellar cistern, prepontine cistern, mammalopontine distance, in fact, were just as predictive and independently predictive of that than that pachymeningeal enhancement. In other words, this patient would have met criteria for suprasellar distance, which should be greater than 4, but here is only 2.6. Mammalopontine distance should be greater than 6.5. It's only 6.2 here. And prepontine distance should be greater than 5. All right? Now, to be fair to the people who read this MRI, they read this MRI a year or two before this paper came out, right? I'm not saying they did a bad job. I'm saying that how we do it today needs to be updated and needs to be better, because this was read as a normal MRI, and in the state of Mississippi, if you have a normal MRI, unless Christina Treppendahl is pushing you forward, you ain't going to get treated for your leak, right? So, also notice that while her pituitary is not greater than 10 millimeters, it's only 7.67 millimeters. In that paper, what they found was among the leakers, the average pituitary height was 7.6. Among the controls, it was only 4.9. And in fact, there's 2 other papers that talk about pituitary enlargement being predictive of CSF leaks. They don't use 10 millimeters as the cutoff. They use 8.5 millimeters. So this might have been read as reassuring, her 7.6 millimeters, but in fact, that's right in line with the 56 cases of CT myelogram confirmed CSF leak. That should not have been reassuring to her doctors. The other thing, again, the superior surface of the pituitary. Among leakers, it's convex up most of the time, whereas in controls, that's pretty uncommon, and that's a significant p-value. Notice the top surface is convex up there, all right? If you're a teenager, everyone's like that, but if you're a 35-year-old woman, not so much. All right, now, that led us to problem number 2. Where are we going to go looking for the leak? So we did the MRI. The MRI is non-invasive. This is a good kind of MRI to look for a leak. It's a highly T2 weighted fat suppressed image. Again, the subcutaneous fat disappears. So you're hoping if any fluid's leaking out here, you'll see like some fluid in the epidural space. We don't. This is what the axial looks like. I do want to point out on this MRI, there's a teeny little line of brightness right there. I don't know how easy it is to see from the back of the room, but that, it turns out, is going to be important. Also, because of the neck pain that she had been having ever since her symptoms started, she saw a neurosurgeon who tried to help her and focused on a bulging disc in her neck and gave her a disc replacement. This looks worse than it is because this is metallic artifact bloom on the MRI. I'll show you on the myelogram what that looks like, but we were worried that maybe the leak would be up here. But I will tell you, I have seen a number of people who have had surgeons go in and try and help them by doing fusions or disc replacements because of their neck pain when the neck pain is from a leak. And you'll remember on her 48-hour flat test that the neck pain got much better when she just stayed flat, right? So that's what the disc replacement looks like on the X-ray. That's what it looks like on a myelogram. Now suddenly nothing's really pressing on the thecal sac there. And in fact, if you look at the axials, there's no spread of contrast out along the nerve roots. It looks pretty reassuring where the surgery was. On the other hand, down at L5-S1, where I showed you that teeny little line, on the myelogram, clear as day, you can see that she has a lamina fracture. Somehow or other, she managed to break her lamina, and the edge of the fracture comes right up to the CSF-surrounded nerve root here on the right-hand side, right? Now, I have to tell you, as I put this talk together, I feel a little bit like a moron because she also complained of some radicular pain going down the foot. And in retrospect, that fracture in someone with some brain findings and an orthostatic headache and some symptoms going down the nerve root at that same thing, I should have started just patching just there right from the beginning. But it took me a while to focus on that at the exclusion of other sites in her spine. Ultimately, what we wound up doing is putting a needle above and below the fracture site, the fracture being right in here on the lamina. That's what it looks like in AP. One needle there, one needle there. The fracture's in the lamina right here on the right. It's on the opposite side now because on fluoroscopy the images aren't crossed. After giving the glue, so we wound up patching this with glue, you can see the contrast that we injected before injecting the glue well covers the fracture site here and spreads up about half a vertebral segment and down along the S1 nerve root as well. The other thing I want to point out to you is that despite having 6 cc's of glue, if you look at the left side of midline, there is 0 spread to the contralateral side. In this case, it's not important. We know that the fracture site's on the right-hand side, but I want to point out to you, you can drop 2 needles in the epidural space, and if you think you're covering the whole epidural space and they happen to be on the right-hand side, you may not get any spread at all on the opposite side of midline. And if you have someone who you think has a leak and you send them to your local pain specialist to do a blood patch, or they go to the ER to get a blood patch after a lumbar puncture, and they happen to land on the wrong side of midline, but their puncture's on the other side, they may get no coverage whatsoever. All right. So it wasn't all that simple because I got it wrong over and over and over again at first. I was distracted by the fusion in her neck. I was distracted by other levels in her spine. This is when I patched her in her thoracic spine. This is me trying to get some some blood up by the fusion. There it is going in a catheter I put into her epidural space beneath her surgery site. And why didn't I give up? Because I had those MRI brain things that we now understand to be important. I had those really striking findings on the 48-hour flat test. And I saw that with some of the patches where I patched at multiple levels, including that L5-S1 fracture, that she was better for several weeks. I just didn't know which patch I had done that had made her better. And now she's in rebound high pressure, which is not the world's most fun thing, but it's better than having a leak. Turns out some people who have a prolonged CSF leak, when you seal the leak, they're now either overproducing CSF or able to absorb it, and so they wind up with what looks like pseudotumor. They have head pain that's worse when flat, better when upright, gets better with diuretics, including Diamox. The literature that's out there suggests that that gradually gets better for most people, but it's not well researched. I'm going to tell you about another case. 35-year-old woman with a family history of brain cancer. Because of the history of brain cancer, she gets routine scans, and one of these found some white matter lesions on a scan, and there was then concern for multiple sclerosis, and so she had a spinal tap. You know, this is the bane of my existence. So she had a spinal tap due to this white matter lesion, and after the spinal tap, she had a spinal headache, 10 out of 10. It was recognized, and they went ahead and offered her a blood patch the next day, and she was then headache-free for a month. But then she started having little headaches coming back, but they weren't so bad. She was only having a headache like twice a week. Then in 2013, 2 years later, she gets an epidural for the vaginal birth of her second child, all right? When you have a vaginal birth, you're pushing. And I don't know if I went by it too fast, but basically, when I showed you that list of the inciting factors for people who were able to identify a precipitating factor for their CSF leaks, the one big category that counted for about a third of those people was a strong Valsalva maneuver, okay? There is no stronger Valsalva maneuver than trying to push a baby out your pelvis, all right? So she basically gets a tap, gets a blood patch, is mostly better, and then she has the world's biggest Valsalva maneuver, and her headaches get worse, and they stay worse, and they keep getting worse. Somebody here said, that's a good enough story, and they went ahead and offered her a blood patch, and she got much better for about 3 weeks, then the headaches returned, tried again, got better for a few weeks, headaches returned, not so good with the second patch, maybe because it was on the wrong side of midline. Then got another patch, again good relief, but it comes back 3 or 4 weeks later. Her patches just aren't holding her. They're not quite getting where they need to be. This is what her 48-hour flat test looked like. Again, a real striking component of getting flat. It doesn't go away completely. She's going from an 8 to a 3. After she gets back upright, it's a 5 in terms of her head pain. Neck pain gets a lot better, 7 to a 2. Nausea gets much better, 9 to a 2. Cognitive symptoms much better, 9 to a 5. Tinnitus, 5 to a 0. Fatigue. And I want to point out to you that unlike some of the headaches that you might see in primary headaches, this is a real syndrome. This isn't just about head pain. These people are debilitated by symptoms that have nothing to do with head pain. Neck pain, nausea, cognitive symptoms, difficulty thinking, rated as a 9 out of 10. This is all kinds of more than just head pain. And I put this up because I wanted to show you what can happen after a known dural puncture. So there's a lot on this image. This is a CT myelogram of a young woman out at Stanford who had surgery on her leg. She developed CRPS in her leg. Not good. All right, complex regional pain syndrome, this kind of neuropathic pain in her leg. As part of the treatment of that, some very well-meaning pain specialists tried to put in a spinal cord stimulator, and when they tried, they accidentally punctured the dura. They knew they had punctured the dura, and they tried patching her. And it was not recognized by her or them that, in fact, she had gone on to develop a chronic leak until much later. When we finally realized that she had a chronic leak, and it was because of the dural puncture that had never really totally sealed, she underwent, it was a long process, but ultimately got a myelogram that shows this, okay? Here's the spinal cord stim lead that they eventually put in, and right next to it is a little bleb that's full of contrast from the myelogram, where her dura didn't really quite seal the way you would imagine the dura sealing would be. She's got like a little kind of almost aneurysmal dilation, a little blueberry-like bleb attached to her dura that at surgery was found to, in fact, be this friable, semi-sealed thing that, was leaking. And she just couldn't seal it. That's what it looks like a little bigger. And this is what it can look like. This is somebody who had the same kind of injury. It's not a picture from her surgery, but the same thing. Again, a large trocar made a dural hole, and then instead of sealing the way it should, so here's the dura, and this thing that looks like a potato bug is actually a little bleb on the surface that could not be fixed by patching. Putting glue or blood on this would make it better for a few weeks, and then it would come back. And what it looks like after surgery is this. The little potato bug is gone. There's now a suture where that was because it was seen to be leaking. Again, the potato bug here, and now it's gone. All right? And so when we're talking about the case of the woman who had the spinal tap that then got better, and then she was doing okay, then she pushed her baby out and now is having symptoms again, I'm worried she's got something like this. Okay? So her MRI brain, again, no pachymeningeal enhancement. The cerebellar tonsils really are not below the foramen magnum. Her suprasellar distance is 4.42. Remember we said that the threshold for this is 4. So this distance is normal. This distance, the mammalopontine distance, is supposed to be greater than 6.5, not greater than 6.5. Prepontine distance should be greater than 5. Not greater than 5. Again, read as normal, but this was done before that paper came out. But I'll tell you, I think in most of the country, they would still read this as normal. So we had her go back and get the images from her lumbar puncture for the MS workup, which was done under fluoro. And you can see, A, that it looks like the needle, in fact, enters on the left side of midline. A little hard to tell. And B, the other thing we were worried about, is this going to play for us? No, it's not. All right. So it looked like her stick was on the left side of midline. And so when we patched her, we deliberately made sure we dropped one needle on the left side of midline. And remember, see here again, here's a different patient, the same finding. You give contrast through this needle that's on the left side of midline, you don't get any spread at all to the right side. And because she came a long way, I wanted to make sure that I got both sides of midline in case they really hadn't been on the left side of midline. And then when I give her contrast through the needle on the right-hand side, now you can see contrast covering the right-hand side too, again. Here's when you only have one needle in, no contrast spread at all to the other side. So imagine her blind lumbar patches that she had that didn't really work. What if they just happened to land on the wrong side of midline, right? All you got to do is drop a second needle. Now, one of the things I was worried about is shown here, the lateral view when they did that lumbar puncture for her MS. The dorsal surface of the thecal sac is somewhere back here. The ventral surface, the front surface, is right there. I'm looking at this and I'm thinking there's some decent chance that they actually went through and through to the front surface. And what would be the problem with that? So on a myelogram, imagine they just put their needle through the back surface, where this is where you normally get your hole for a post-dural puncture headache, but they don't realize they're in far enough, they keep going, they go through the front surface. What if you have one of those blebs on the front surface? Well, that could be a problem. This is what it looks like on a myelogram after an epidural blood patch. So this person has spread on both sides of midline, but notice it's just pushing the back surface of the bag of fluid in. None of the blood injected in this patch is getting to the front surface at all. This idea that you're going to do a patch and it's just going to spread where it needs to go is just nonsense. It may not spread to the other side of midline, and it may not spread to the front surface if that's where the hole happens to be, which is what we're worried about in her, and exactly where the hole was with that woman who had the classic case of the leak, right? That bone spur was poking into the front surface of the bag, not the back surface that is easily patched when you have a post-dural puncture headache, right? Most of the time when a doctor makes a leak, they do it by sticking a needle in the back and poking into the back surface. We don't usually go through and through, so usually the hole is right on this surface that this patch is good at sealing. But if you happen to not realize you're in, like you're doing a lumbar puncture, you draw back the stylet, you look, you don't see fluid, you keep going, right? Oh, you went through. Okay, now you've got the leak on the front surface. Now you've got a problem because your spread is here, but what you may need is spread there. And so if you want to get spread there, you've got to put in a needle like this, not just inject there. You got to get into that plane. So that's what we're doing here with this needle. We've now rotated obliquely to come in on that oblique angle I just showed you. You see it coming into the foramen here, and the spread even looks different in that ventral epidural space. And this is what it looks like on a lateral. Here's the vertebral column. The disc is here. And you can see now, with this needle coming in the foramen, I get all the way to the front of the epidural space, which is here. And you can see the contrast outlining the back surface of the disc because I'm in the front of the epidural space. All right? Her headache was resolved for a month and then returned, but, quote, I'm still having some headache-free days, but I've had several days with head pain, neck pain, and dizziness causing me to miss a couple of days of work and stay in bed. So she's better, but she's not fixed still. And the message here is that proper patches, which she had 3 of, can fail to resolve a leak due to that kind of bleb anatomy or due to the contrast not crossing over the midline, because many people have a fibrous band in their epidural space called a plica mediana dorsalis, or it may fail because of a ventral dural puncture. So if somebody looks like they have a headache after a dural puncture and they get an epidural blood patch and it doesn't work, you can't just wash your hands and say, oh, it must be migraine. Because there's 3 reasons why that blood patch might not have worked. All right, third case. 43-year-old woman, 2010, her son is born. She recovers with no problem. It was a vaginal birth with an epidural, no problems afterwards. However, between 2010 and 2012, she starts having more chronic issues, which we'll get into. In this time period, she has one hard fall in the garage, where she falls back, she hits her head on the concrete. This is her 48-hour flat test. Again, head pain goes from an 8 to a 3. Within 2 hours of standing up at the end, she's back to a 9. Neck pain, 4, 2 hours afterwards, back to an 8. Nausea gets better a little bit, but not that much, 3 to a 2. 2 hours after getting upright, back to a 5. Cognitive symptoms completely resolve when she's flat. And these kind of cognitive symptoms, let me say, they're difficulty concentrating, difficulty with memory, the kind of thing that people describe as brain fog. All right? Brain fog shouldn't get better when you're flat. Tinnitus goes away and fatigue goes away too. Her MRI, again, shows no pachymeningeal enhancement. You know now that if the pituitary is upgoing, that's a potential sign of an issue. When you measure, her prepontine distance meets criteria of being less than 5 millimeters. Her suprasellar distance, it's cut off, also met criteria. And her pituitary is 7.05. Remember that in the controls, it was only 4.5. So some soft, non-diagnostic stuff that increases the probability that she, in fact, has a leak. Her CT myelogram showed a reversal of the cervical lordosis. And at a couple of levels, there's a little disc here. I think this is 5-6. And you see this asymmetric spread of contrast out along the adjacent nerve root pretty far. And it's not just in one plane. It seems like maybe there's a little bit of something there, too. In her mid-thoracic spine, again, this is T12, so the yellow line here is showing you where this cut is coming from. You've got this asymmetrically opacified nerve root on the left-hand side. This is the thoracic epidural blood patch. The needle's coming in here, injecting contrast there. And this was injecting epidural blood in the epidural space of her neck. She reported after that, my headaches are significantly better, but I still have them daily. They're not nearly as intense and do not last all day like they did before. I'll have a headache now ranging from 15 minutes to maybe an hour. A couple have lasted 2 to 3 hours. I can go without sunglasses constantly during parts of the day, whereas before I had to wear them constantly. So we went ahead and repeated her patch, and the latest update is that she had 2 days with no headache at all, and the other days have only been twinges of pain, and then it's gone. Last case, 52-year-old woman had head pain that started in elementary school. A little different than the others. It didn't start on a particular day late in life. So head pain starts in elementary school. Then in 1992, things get worse during her divorce. She's had 2 spinal anesthetics, meaning dural punctures for childbirth. Her 48-hour flat test Head pain again gets better, 5 to a 2. Neck pain goes away completely, 6 to a 0. Fatigue goes away completely, 6 to a 0. We thought it was good enough to take a run at it. And this is what her MRI looks like. You could maybe eyeball that without calipers and say, that looks a little narrow. And maybe her cerebellar tonsils are a little low there. No pachymeningeal enhancement again, which means in most of the country, this does not get read as a leak. You can see when you, in fact, draw McRae's line that her cerebellar tonsils are below it. Not enough to call it a Chiari, but a little cerebellar ectopia. Her prepontine distance is 2.74. Remember, it should be greater than 5. And her mammalopontine distance is 5.4. It should be greater than 6.5. So again, meets criteria for what predicts an increased likelihood of having a positive CT myelogram. When we get her myelogram, we see that she's got a number of kind of spondylitic changes where she's got little bone spurs pressing on the thecal sac, including here, where you see again this nice asymmetrically opacified nerve root at the same level. Another level down, little calcified stuff pushing on here, asymmetric opacification of the nerve root there and there. And at this level, not only do you have contrast here, but you've got it way out here. This is the nerve root that's opacifying. So she's got some unusual spread of contrast along the nerve roots, and this may be an actual perineural cyst where it's kind of a dilated aneurysm of the nerve root that has a propensity. These things have the ability to pop and leak. Unfortunately, she's got even bigger ones down in her thoracic spine. Look at this. This whole kind of aneurysmal thing coming off the thecal sac, and then something coming off of that with even more dilute contrast here. This is kind of the most suspicious place because you've got the known structure that can leak. It's big. And then you've got some poorly defined borders where the contrast is not just up against the border and has a sharp border. Another cut in just a couple of millimeters away. Again, you know, this was read by our radiographers as suspicious for a leak. And right below it, possibly giving rise to this, is this. A disc with a little calcium spike, again, coming in towards the thecal sac. Unfortunately, she's got other levels where she's got calcium poking in at the thecal sac as well, there and there. And so now we have a problem of riches. Too many places where we have suspicious things that can contribute to leaks. These aneurysmal dilatations and calcifications. And sometimes these things, these perineural cysts, can actually pop into a vein. There's veins on the outside of them, and they can pop and then release spinal fluid into the vein. And it's like the vein is a leech on the perineural cyst, and the spinal fluid is leaking into the vein, what's called a CSF venous fistula. And you will see no collection of CSF on the myelogram because it's all disappearing into a vein. And in fact, you can see it if you do something called a digital subtraction myelogram. This is someone who got a myelogram while they're in the lateral decubitus position so that the hyperdense, undiluted contrast can pool on the side. And in fact, this stuff here, this kind of hazy stuff, is a CSF venous fistula, is some of the contrast escaping. This is someone else who has it in a little more of a brisk leak into the veins, and you can see the perineural cyst here, and then this stringy, strandy stuff. That's contrast escaping into the veins. So from her first patch, which we did near that big dilated perineural cyst, she was completely headache-free for 11 days, but then her headaches returned. We went after a slightly different level with glue, and she had no benefit. And I'm not sure which of the many places in her spine that looks kind of suspicious but doesn't show a frank leak I should go after next. So these are the problems that we run into with these patients. So my overall conclusions that I would leave you with, what did these patients all have in common? The first is they all had MRIs that were read as negative. The teaching case that I showed you aside from the beginning, because I wanted to show you a classic thing first. And yet they all had positive brain findings consistent with recent literature, all of them. They had compelling 48-hour flat tested, and they all benefited to some degree from patching. And they were all from the same little area of Mississippi. All right? So for those of you who are out there treating spinal fluid leaks, why can Christina Treppendahl be so much better at finding these than everybody else in the country? All right? In fact, I would put to you that 5 years ago at Stanford, we were diagnosing these about as infrequently as everybody else. And then we got turned on to the literature of this and started looking harder and knowing what to look for. And then we started finding them in all kinds of people that had been refractory headache patients or refractory nausea patients or refractory tinnitus patients. And the more you read about this and the more you plug into this, the more you start to see that a lot of these patients are trying to tell you they have postural symptoms. I'm pretty good when I wake up in the morning. The second half of the day is always hard for me, right? That 48-hour flat test does not require insurance approval. It's an easy one, right? And then when you try to get your MRI from the insurance and they start giving you some pushback, you know, talking about, look, they had this, and this symptom when they were upright, and when they stayed flat, it went better, and we've quantified it, and it's in the medical record. Hard for them to argue with that. We need to change the way we think about brain MRIs. And this kind of stuff that I'm showing you should have you thinking about, should we be treating CSF leaks as a clinical diagnosis rather than a radiologic diagnosis? We don't treat septic shock as a radiologic diagnosis. We don't treat lupus as a radiologic diagnosis. What's the basis for treating CSF leaks as a radiologic diagnosis? And then the last thing, persistence and not genius is what makes patients better. The reason that the patients who got better is because somebody here advocated for them and somebody at Stanford wasn't willing to let it go. If you're interested in this, that's my email. One of these is a QR code for a Google Drive folder that I share with patients and physicians around the country. It has the articles that I cited earlier. One of these is a QR code for the Spinal CSF Leak Foundation, and one of them is a link to if you want to come and make an appointment and see us out in California. So if you take a picture of that, you can always scan it later. All right, that's it. That's what I got for you.